Warm welcome to all of you, all the faculties and all the attendees, because I've been shocked when I read for the first time the number 10,000. I know India is big, but 10,000 is a lot. 10,000 people interested in a very special topic. So I wasn't that angry about the topic, because I know, once you get dusty, you just have to do something against it. So I probably learned a lot just by that topic. And just on behalf of the Swiss Association for Hernia Surgery, I'd like to welcome you all, because our society has got 59 members, and the Indian group, abdominal wall surgeons, are over 4,000. So there's a little disproportion, but that doesn't make the difference. So, well, these are my disclosures. The most important that I love hernia meetings, but in person. I'd like to see you again, Barbara, like the last time we did. Well, the history of loss of domain, it's a kind of a privilege and a burden to talk about something where it's so little written about and so little actually standardized, but I took the chance and made the best of it. History of an enigma. Well, I remembered that somebody from Argentina, whose name is Goñi Moreno, 1940, published something, and he published it in English, because it was always the same objections. But the South Americans and North Americans, more of the time, they are devoted to this type of procedures that were maybe very peculiar for us. So I talked to Juan Carlos Mayagotia in Mexico. I mailed with Fernando Carbonell Tatay in Valencia in Spain, talked to several Argentinians if they have anything more than that what we know about this guy, because some hernia topics have a long history, others don't. For example, the term ventral hernia was for the first time used in 1728 by a French surgeon, Garangeo. But what about this topic, loss of domain, in the past? In 1912, the French Academy gave out a booklet about how to treat big hernias with bandages and trusses. And 1984, when I opened my surgical office in Zurich, I bought myself a famous standard surgical Bible, which was Lloyd Nehu's Mastery of Surgery. In that book of 1,400 pages, there is no chapter on abdominal wall hernias. How do you think anybody would care about complex hernia or even loss of domain? And this was 1984. Yeah, there were some people. Goñi Ivan Moreno, the surgeon who recognized the importance of volume of hernia and used the terms right of domicile and second abdomen already then. 1940, he published for the Argentinian Society something, or it was unique technique. He was injecting oxygen first in a patient with an incarcerated incisional hernia, and the patient did well afterwards. So, and this was apparently for the first time that the pneumoperitoneum has been used for therapeutic purposes, called progressive preoperative pneumoperitoneum. Well, let's use his words. The disproportion between the abdominal container and its contents, second abdomen, lost the right of domicile. It would be an embarrassment if you would put all these contents suddenly back to the cavity. And because of the excessive tension that you would need, he was afraid of recurrences. Well, he must have had LOD in mind. These are the original drawings. He published it in English in 1947 in the Journal of Surgery. Well, the effects of sudden increase in abdominal tension, he realized that the weight reduction principle was insufficient. He realized that intra-abdominal pressure was important, not the number of liters, because the useful effect to enlarge a cavity was by the pressure of the gas and not by the liters. And there is no relation between the number injected of air and the intraperitoneal pressure. Well, there are different classifications of abdominal wall hernias, but none of those mentions the volume of hernia sac. Loss of domain versus loss of right of the domain. Well, Parker, in his paper 2019, raised the discussion whether it was correct loss of domain or loss of right of the domain, because contraction of the lateral strap muscles would decrease the abdominal cavity volume. That was a truly loss of cavity volume. An early adopter of progressive pneumoperitoneum, Dr. Johnson, published in 1972, something that he believes that abdominal viscera stay in such a long time out, they lose the right to belong inside of the abdominal cavity. Whatever it is, but the anatomical and functional changes were already known to Jean Brief in 1973. He called it eventration disease. Muscle that retracts laterally, hernia enlarges, disuse atrophy, irreversible muscular fibrosis, strap muscles get shorter and thicker, the intra-abdominal pressure lowers, that causes descent of diaphragm and respiratory dysfunction. The mesenteric and bowel wall edema causes increase of the content, and the unsupported spine causes chronic back pain. Also, Parker was right when he called his paper what exactly is meant by the loss of domain. He wanted to find out the definitions. He found 1/3 had a written definition, but 2/3 used the word of loss of domain as a concept without any definition. And only 1/4 used volumetric definition. We will hear from Eduardo Tanaka afterwards. I will leave it here. Of course, that the cutoff threshold or percentage proportion above which loss of domain becomes clinically significant is of importance. This is what we would like to have. Well, Samuel Parker used another 19 surgeons as experts in a Delphi consensus and found out a definition which is, in my eyes, not much better than anything which was said before, but a ventral hernia large enough that the fascial closure either cannot be achieved without additional reconstructive techniques, or it cannot be achieved without significant risk of complications due to the raised intra-abdominal pressure. Why are we so concerned about the loss of domain? Well, the primary closure can cause intra-abdominal hypertension and abdominal compartment syndrome. The World Society of the ACS, that I had no notice about until I prepared this topic, demonstrates very nicely with increasing intra-abdominal pressure rises the mortality of the patients. Substantial loss of domain causes recurrences, and there is no consensus until now on the loss of domain threshold predicting postoperative failure. So what are the lessons that we've learned from the past? We have several ways how to reduce the risk of ACS. And today I may add one more. We will hear about it later in the session 3, the perioperative expansion of abdominal wall called fascial tense. And if I ask our captain what he sees on the horizon, he would say, yeah, fine, it will be a good content. But humble myself, I would say today will become historical. And I wish you all a great conference. And donate the next 30 seconds to the next speaker.